Okay, coming back to this here. So what do we have? We have this vasoactive intestinal polypeptide. Vasoactive V, intestinal I, polypeptide P, VIPs. Where they're located, they are the parasympathetic ganglia, the sphincter, gallbladder, and small intestine. They increase intestinal water, electrolyte secretion, very important. Increase relaxation of intestinal smooth muscles and sphincters, very important. What regulates them? It is their increase by distension and vagal stimulation, decreased by adrenergic input. Now you have a vipoma. That is a non-alpha, non-beta islet cell pancreatic tumor that secretes VIP. That is going to be associated with VDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. Okay, watery diarrhea. Again, watery diarrhea is like secretory, like cholera type diarrhea. Okay, same thing like cholera. It's also known as, the other name to this thing is also called pancreatic cholera. Because why pancreatic? Because the pancreas are the ones which are secreting VIP. Because it's this pancreatic tumor, vipoma. Okay. What else? It's a T-colored. One more thing, it's a T-colored odorless long-standing secretory diarrhea. So VIP secretes the bicarb, electrolytes, secretion into the lumen. That's going to go straight out. Okay, and this is hypokalemia due to high volume diarrhea. Okay, and achlorhydria because of the absence of the gastric acid. No gastric acids. Okay, so you have how do you diagnose it? Endoscopy will show you increase in the pH. Why increase in pH? Because the VIP was stimulating the bicarb. It was stimulating the bicarb and chloride secretions. So when you have a bicarb and the chloride in the lumen of the gut, let's say, let me erase this. Let's say you have this is the lumen and you got the bicarb and you have the chloride in the lumen. This draws the water inside the lumen, hence watery diarrhea, but it's secretory type. Okay, and so when you draw all of this and causes watery diarrhea, everything goes out, and this is bicarb. This neutralizes your acid, so you have achlorhydria. And, when you do the endoscopy, and in the serum, first of all, in the serum you will have increased VIP because it's vipoma. Second thing, in endoscopy you have increase in the pH of the stomach. Normally it shouldn't be increased; it should have been decreased. So how do you treat this vipoma? Well, the way treatment goes is first of all you want to give fluids or electrolyte replacements. Then again give octreotide, which is going to inhibit your VIPs. VIP secretion, so that's the way to go. All right, coming back to nitric oxide, that increases the smooth muscle relaxation, including the lower esophageal sphincter, LES. Loss of NO is implicated in increase in LES tone in achalasia. Right, remember in achalasia, you had the loss of inhibitory neurons. Right, and those inhibitory neurons, which are the nitric oxide and something else, which we'll learn later. But because of that, you have increased LES tone. Why? Because normally the NO was relaxing the LES, relaxes LES. So when you don't have this, you're increasing the LES. You can't relax. So when you can't relax, that's achalasia. Now let's talk about ghrelin. Ghrelin, that's coming from stomach. increases appetite. Ghrelin makes you grow, like, right? Increases appetite. Increase in the fasting state decreased by food. More also clinical tie-in. Increase in the Prader-Willi syndrome and decrease after the gastric bypass surgery. Okay, so if you are increasing the appetite, you're causing weight gain, right? So what's the other hormone that is like opposite to this thing? That is your leptin. So the ghrelin is making you grow, makes you hungry grow. Remember that mnemonic thing? And the leptin is making you thin. And now let's talk about when are they released. We said the ghrelin is released in the fasting state. Well, the leptin is released after the meal. So after a meal, leptin comes, okay, and leptin inhibits your appetite center in the hypothalamus, which causes satiety. Okay, because that's after a meal. On the other hand, this guy, ghrelin, comes in the fasting state, okay, and it stimulates the appetite center and makes you hungry. In obesity, you have dysregulation of all of this and this. So basically, leptin is coming from where? The adipocytes, remember? Leptin is coming from adipocytes, adipose cells. So when you have dysregulation, no matter how much you're eating, your brain is not like, it's not getting all of that input. You keep eating, leading to obesity. But that's one of the things. It's not the only thing. But coming back to, let's say if they give you a graph, which they are going to give you a graph. So they will say, okay, you have this plasma levels on one side, and you have this patient with the gastric bypass surgery, like gastric surgery, and also you have the normal patients. So we said that it decreases in the gastric surgeries, right? So what's happening to the levels when you have some food? So you had this breakfast, lunch, dinner. So remember, the ghrelin is coming only in the fasting state. So as soon as you have your food, no matter which food you are taking, it's going to go down after that. Wait, what did I do here? It's going to go down after that. There's a peak. We are talking about ghrelin here. There's a peak, but as soon as you have that food, it's going to go down after that. But again, you have food, it's going to go up. As soon as you have food, it's going to go down. You have food, you think about the food, or the dinner is going to be served, it's going to go up, and it's going to go down after that. That's the normal state. But in the gastric surgery patients, it's just plain. Okay. Which leads to when you have the gastric surgery, nobody's stimulating this appetite center. You're not getting hungry. And you're not getting hungry. There's called the weight loss now. You're going into weight loss. Okay, that's a tie-in here. But let's move on with the next thing. Where are we? Okay. Here, what do we have? We have this gastric acid. Well, the gastric acid coming from the parietal cells of the stomach. Yeah, it decreases the pH. Yes, it's acid. That is regulated by increase by histamine, vagal stimulation, which decreases acetylcholine and gastrin. It is decreased by somatostatin GIP, prostaglandin, and secretin. Okay. Notes autoimmune destructions of parietal cell. If you have an autoimmune destruction of the parietal cells, it leads to chronic gastritis and pernicious anemia. Okay. And pernicious anemia is due to deficiency of pernicious anemia meaning like megaloblastic anemia, deficiency of vitamin B12. Why? Because you can't make your intrinsic factors to get attached to vitamin B12 and to absorb that. So it causes anemia, pernicious anemia. Intrinsic factor, parietal cells coming from, remember, gastric acid coming from parietal cells, intrinsic factor coming from parietal cells. Vitamin B12 binding protein required for vitamin B12 uptake in the terminal ileum. If you have anything surgery that removes terminal ileum, again, pernicious anemia. Okay. So let's talk about something called pepsin now. What is pepsin? First of all, pepsinogen. Nogen, it is an inactive state. It is converted to pepsin by acid. Okay, so that is an active state. It is coming from the chief cells of the stomach. Remember, we did this yesterday. Chief cells are the blue cells, right? Basophilic, dark basophilic cytoplasmic cells, and they are present in the deeper portion of lamina propria. So deeper portion of the lamina propria, while the other ones, which are the parietal cells, these are your pink eosinophilic cells. Pink means eosinophilic cells, cytoplasm, and they are present in the upper portion of the lamina propria. So this is deep, this is upper of lamina propria, Okay. So just remember, as it is mentioned here, parietal cells are like up, chief cells are down. So deeper portion of the lamina propria, upper portion of the lamina propria, and parietal for P, pink. Chief cells. Okay, one thing is pink, the other guy just got to be blue, right? Okay, so basophilic. Okay, so yeah, let's read the pepsin now. It does the protein digestion, increasing the vagal stimulation and local acid, right? Pepsinogen inactive is converted to pepsin active in the presence of L. Well, I did talk about that already. So let's talk about bicarb now. Bicarb, let me erase this. Bicarb, that is mucosal, coming from mucosal cells of the stomach, duodenum, salivary glands in the pancreas, and the adrenal glands. Very important. So the question is, who secretes the most bicarb? Okay, that's the first thing. Adrenal glands. Remember, we did this yesterday. It is the hallmark of duodenum. These adrenal glands secrete the bicarb. Okay, and these are submucosal glands. Submucosal glands of the duodenum are the adrenal glands, which secretes bicarb. They secrete the most bicarb. What is the second? Who secretes the bicarb at the second highest? Well, that is or maybe you can say the primary source. The primary source of bicarb, number one is the adrenal gland. Number two is we are thinking about epithelial cells of the ducts. So basically, just remember this: ductal cells of the pancreas. So epithelial ductal cells of pancreas. So basically pancreas right here. That's the second most primary source to secrete bicarb. So why is it that important? If you secrete the bicarb, you want to neutralize that acid that is coming down from the stomach. If you can't neutralize that, you can have all that erosions and all that. So this is really important. So increased by pancreatic and biliary secretion with secretin trapped in mucus that covers the gastric epithelium. Okay. Let's talk about what happens when you have, let's say you have the chronic increase in HCl, maybe due to anything, GERD or H. pylori, anything. You have increase in HCl, like a lot of acid, right? So what's going to happen is, well, which cells are going to go into hyperplasia? Well, they are your primary source cells, which are the submucosal Brunner gland cells. They are going to go into hyperplasia. So in the submucosa, you will see hyperplasia of submucosal cells. They are your Brunner glands. Okay, now let's go on to the next thing. What do we have? Location of the GI secretory cells. Okay, let's look at this. G cells secretes the gastrin. Gastrin directly stimulates the parietal cells, but that is only about 10%. The 90%, it goes and stimulates the ECL cells, which are your enterochromaffin-like cells, and that is going to stimulate histamine. That histamine is going to work on the H2 receptor and stimulate the parietal cells. Okay, that's one route of secreting HCl. The other route is the vagus nerve. Again, just think about the vagus does stimulate your G cells by releasing not acetylcholine, but releasing GRP. Over here, it releases the acetylcholine. So vagus stimulates the parietal cell by secreting acetylcholine, and it stimulates the M3 receptor. Okay, and then that secretes the HCl. And the gastrin directly stimulates the parietal cell. So that's 1, 2, and 3. 3 paths that secretes the parietal cells. Okay. What else here? Somatostatin is here at the antrum. Okay, and you can look at the CCK at the duodenum, secretin here, and K cells. Secrete the GIP there. So gastrin increases acid secretion primarily through the effects on the ECL cells, leading to histamine release, rather than through its direct effect on the parietal cells. So again, 10% directly, 90% ECL, which releases the histamine and moves on. Okay, so let me just do one thing here. Okay, so let's go with the pancreatic secretions. Very important. What do we have? So we have isotonic fluid. Isotonic basically means same as plasma. It's the same concentration as plasma. But you have two different things here. You got a low flow and a high flow. When you think about low flow, you are secreting high chloride and low bicarb. Okay, that's a low flow. I'm going to explain how, but just keep in mind that's a low flow. High flow, you have high bicarb, but low chloride. Okay, so let's talk about how. So bicarb gets secreted from the ductal cells. Okay, one more. Let's talk about that as well. So you have the ducts, which are called ductal cells. Again, here too. And you have the acinar cells. These are the acinites. And you have these acinar cells. Acinar and ductal. Acinar cells, they secrete enzymes, while the ductal cells, they secrete the electrolytes. Okay, so when you talk about high flow and low flow, what happens is, in low flow, the bicarb, if you are having low flow, if you're having low flow, means low flow is coming out of these ducts. So what's going to happen is this bicarb is going to get reabsorbed. My bad. Is going to get reabsorbed. So all you're left with is the chloride, where the bicarb gets reabsorbed in exchange of chloride. I hope this makes sense. The bicarb gets reabsorbed in exchange for chloride. So in your low flow, you are secreting chloride only. High chlorides in your low flow. Why? Because the bicarb gets reabsorbed because of the low flow. So just think about it this way: because the bicarb is staying there so much that the channels have the time to pull it back, and chloride comes down, right? But if you are having a high flow, what happens in high flow, the bicarb doesn't get reabsorbed because you're going so fast that these channels don't even have time to reabsorb you and chloride to come down. So you have the high bicarb to go out. Okay, so flow rate changes the concentration of the bicarb and chloride as the bicarb gets secreted from small ducts. So again, if you're going into low flow rate, the bicarb will get reabsorbed in exchange of chloride. And in the high flow, you have the bicarb flow very quickly so that the reabsorption doesn't occur, and you have the high bicarb flow. I hope that does make sense. Okay, so so that's the high flow and the low flow. Now let's talk about something which is weird. When do we have the low flow and when do we have the high flow? Well, we have the low flow in the fasting. In the fasting, we don't need bicarb, right? Just think about like your mind. When do we need bicarb? We need the bicarb when we have a lot of acid coming down. We're like, man, how are we gonna neutralize that acid? We need the bicarb. But in fasting, there is no acid, there's no food, so we don't need nothing. So here comes low flow. Low flow is gonna get a lot of chloride out. That is in fasting state. But what about the high flow? High flow, that's gonna come in after you take a meal. You eat the food comes down, you want to neutralize that acid. High flow. Awesome. Let's talk about these enzymes now. Okay. Alpha amylase, starch digestion. This is like a complex carb. Okay, it is secreted in active form. So this is secreted already in active form. Doesn't need to be a pro type and then it goes into active. No, it's just active form that comes down. lipases, fat digestion. Okay. How? Just think about triglycerides. Remember, we need those lipases, which act on these triglycerides and convert them into free fatty acids and monoglycerides or glycerides. Those are the lipases. Now let's talk about proteases. Well, proteases, these are pro-enzymes in inactive form. So we need that for protein digestion. Their active form includes trypsin, chymotrypsin, elastase, and carboxypeptidase. These are their active forms. They are secreted as proenzymes, also called zymogens. Dipeptides and tripeptides degraded within the intestinal mucosa via intracellular processes. Give me 1 second. What do we have there? Okay, awesome. Then what do you have here? So these proenzymes, also called these proteases, also called zymogens, as we mentioned, zymogens, proenzymes, same thing. They're needed for the protein digestion. So now they have mentioned one of them, which is called trypsinogen. Trypsinogen gets into trypsin by the activity of your enterokinases. So you have the enterokinases they have mentioned it there. So trypsin is converted to trypsin by enterokinase and enteropeptidase. So where is enterokinase? That is in your duodenum. And where is enteropeptidase? That is in your jejunum. Okay, so you need these two brush butter enzymes to activate trypsinogen, which is a proenzyme converted to an active state, which is trypsin. Now trypsin, this guy's going to do the main work now. Well, it's going to go and it's going to activate all of its siblings. It's going to activate its chymotrypsinogen into chymotrypsin. It's going to activate proelastases into elastases. It's going to activate procarboxypeptidases into carboxypeptidase. All the proenzymes is going to activate them. Okay, but it needs what? You need the brush butter enzymes to activate this guy. Okay, so when we need the brush butter enzymes, guess what? If you have a deficiency of one of them, the brush butter enzymes, you messed up. You can't activate it. So let's talk about, let's read this and then we will talk about some of that. Trypsinogen is converted to active form trypsin, leads to activation of other proenzymes and cleaving of the additional trypsinogen molecules into active trypsin. Positive feedback loop. Positive feedback loops meaning trypsin activates itself. So if you have a trypsin, you got this. Once you make a trypsin, you're activating it yourself. That's a positive feedback instead of negative feedback, which inhibits it. So it has a positive feedback on itself. So here, let's talk about now like some cytopathologies. So if you have a deficiency of your enteropeptidase deficiency, now you can't digest proteins and fats, so leading to fat malabsorption, as trypsin is required to activate these enzymes required for both lipid and protein digestion. So trypsin is required for both the protein digestion and the lipid digestion. So when you have this protein and fats in the bowel, guess what? You're going to have diarrhea, and because this is a congenital thing, so you have a failure to thrive for the child, and you also have edema because of the protein loss. Okay. Something else, some clinical tie-in also. One more thing. We are going to be talking about Physiologically, so let's just go with trypsin here. Trypsin. So physiologically, inhibition of the active trypsin is by something, right? So if this guy is active, who's the guy who inhibits this thing? So normally it is inhibited by trypsin inhibits trypsin by that's one thing. So although they have mentioned the positive feedback, but also there's a negative feedback also on it, that trypsin will inhibit itself also. But most importantly, you have the SNR cells. Remember the SNIs that I mentioned, the SNR cells? So those SNR cells of the pancreas, they are going to secrete an enzyme called SpinK1. That SpinK1, now what is that SpinK1? That is, you just got to know this, but going in details, this is serine peptidase inhibitor K1. Okay, that inhibits the trypsin that is released by the SNR cells. Okay, so now if you have a mutation in your trypsin, if you have a mutation, this guy, as SpinK1, cannot inhibit it because there's a mutation to it, and that is going to cause you trypsin. It becomes insensitive to inhibition, right? That leads to hereditary pancreatitis, because trypsin is just there, is going to cause pancreatitis because you can't inhibit it. Okay, and that's pretty much all we have for this thing. Yeah, so let's talk about the carbohydrate absorption. Well, the carbs, the only monosaccharides, the glucose, galactose, fructose, are absorbed by enterocytes. Glucose and galactose can be taken up by the SGLT1. The sodium-dependent fructose is taken by the facilitated diffusion by GLUT5, 5 for fructose. Okay. All are transported to blood by GLUT2. Okay, look at this image here. So you have this sodium glucose transporter. You're transporting sodium and you're transporting glucose or galactose because they're all monosaccharides. So that's the SGLT1. Okay, and you have this, who else? GLUT5. They are taking up the fructose, GLUT5, F for 5, F for fructose. Okay, and you have this sodium potassium ATPase, which is going to throw out three sodiums into the circulation and picks up 2 potassiums. GLUT2, they are present in the basolateral membrane, and they are the ones which are needed for the monosaccharides to be transported to the blood by GLUT2s. So the clinical thing here is the deoxylose test, which is a simple sugar that is passively absorbed in the proximal small intestine. Blood and urine level decreases with mucosal damage. So it says it passively goes through it. Okay, that deoxylose. But if you have a mucosal damage, for example, in celiac disease, you have that mucosal damage. So you cannot absorb that deoxylose. So when you cannot absorb the deoxylose, you will have a decreased levels. Urine level decreases with mucosal damage. It is so in your celiac disease, you would have a decreased levels. But if you have a pancreatic insufficiency or chronic pancreatitis, you have a normal deoxylose test, because that is due to pancreas. The pancreas has nothing to do with your mucosa, right? Mucosa is all normal. So that's what they're saying, that it will be normal in the pancreatic insufficiency. All right, moving on with the vitamins. and mineral absorptions. Vitamin and mineral deficiencies may develop in patients with small bowel disease, bowel resection, intestinal failure, also called short bowel syndrome, or bariatric surgery, example vitamin B12 deficiency after terminal ileum resection. Iron fist bro. Iron gets absorbed in the duodenum, folate absorbed in small bowel, B12 absorbed in the terminal ileum along with the bile salts requiring intrinsic factor. And looking at this picture of how things work, so you have this salivary R protein or R binder, and you have the animal proteins. So salivary is gonna animal protein goes down, your intrinsic factor from the parietal cell gets secreted. Pepsin digests that protein, cleaves that bicarb on a side and gets the protein on a side. You have the R binder, which binds to the vitamin B12, takes it to the pancreatic proteases. That pancreatic, so we have three processes. So one thing is we need the IF here. One thing. Second thing, we need the pepsin, so that it is. We don't really need that, but the thing here in this image is the vitamin B12 gets cleaved from the protein. But we need this R binder that's going to take it towards the duodenum, in which the proteases of the pancreas, we need this. That's going to remove that R binder, and it's going to attach that intrinsic factor. And that is going to go into the terminal. We need the terminal ileum because that's where the receptor for IF is. It's going to come, gets into the blood. But if you don't have terminal ileum in the bariatric surgeries, guess what? You are vitamin B12 deficient. If you don't have parietal cells, you're vitamin B12 deficient. What else? Yeah, if you don't have acid, if you're blocking those through PPIs, chronic PPI use gives you vitamin B12 deficiency. So, yeah. All right, moving on. Pirate patches. Well, these pirate patches are unencapsulated lymphoid tissues found in the lamina propria and sepicus of the ileum. They contain the specialized microfold M cells that sample and present antigens to immune cells. B cells stimulated in germinal center of the pirate patches. So again, look at this thing. The B cells are stimulated in the germinal center of the pirate patches, differentiated into IgA secreting the plasma cells, which ultimately reside in the lamina propria. IgA receive protective secretory components, and it's transported across the epithelium to the gut to deal with intraluminal antigens. Think of IgA, the intra-gut antibody. So kids, so again, the pirate patches, they're in the lamina propria of the ileum. They have the M cells. M cell, what is the job of these M cells? They're the immune cells, M. They sample and present antigen to the big guy. Who's the big guy here? The B cell. Well, the B cell is going to look at that antigen and it's going to make antibody for it. And that antibody is IgA. IgA is going to go out. It's going to say, hey, let's get you in. And it's just there, and it's going to keep getting that whenever it comes down. So, yeah, that's pretty much all we have for pirate patches. But now, clinical tie-in, shigellosis. In shigellosis, Shigella goes to these M cells. It's like, man, M cells basically capture it by it goes to these M cells actually, not that M cells capture it. It goes like, man, I'm gonna take you down. You're the big guy here. By invading the GI mucosa, as soon as you invade the GI mucosa, these M cells are going to end. It's gonna go into these M cells by endocytosis into these M cells. Okay, that's the shigellosis. Moving on to bile. Bile is composed of bile salts, which are the bile acids conjugated to glycine and taurine, making them water soluble. So bile is composed of bile salts, phospholipids, cholesterol, bilirubin, water, and ions. So bile contains all of this. Cholesterol 7 alpha hydroxylase catalyzes the rate limiting step of bile acid synthesis. The bile acid synthesis is done by the 7 alpha hydroxylase. How? Let me show you how. So these bile salts are the major component, okay, and these bile salts are synthesized in liver, okay. So in the liver you have the cholesterol. Cholesterol needs its 7 alpha hydroxylase enzyme to form hydroxycholesterol. Okay, that hydroxycholesterol becomes, like, if you follow, like, there are a lot of steps there, but it becomes the cholic acid. See, cholic acid and chenodeoxycholic acid. And what are these two things? These two things are the bile salts. So they are saying cholesterol 7 alpha hydroxylase catalyzes the rate limiting of bile acid synthesis. So bile acid synthesis, this is the rate limiting step. If you were to inhibit this, you don't have bile acids or bile salts. You don't have much bile. That's all they're saying. All right, functions. Functions are digestion and absorption of lipids and the fats. The bile does the digestion and absorption of the lipids and the fats, fat-soluble vitamins. Bilirubin and cholesterol excretion. Look, it's a primary means of elimination of cholesterol. Okay. Antimicrobial activity, wire membrane disruption. Decreases absorption of enteric bile salts at distal ileum, as in short bowel syndrome. You have a decreased absorption of bile salts at the distal ileum in the short bowel syndrome or Crohn's disease. Prevents normal fat absorption and may cause bile acid diarrhea because you can't absorb the fats, leading to fats in the gut, causing diarrhea. Calcium, which normally binds the oxalate, binds the fat instead. So the free oxalate, so normally you have the gut, you have the oxalate, the calcium binds it. Okay, in the gut and gets out. But if you don't have the calcium, why? Because the calcium loves to bind to fats. So now you have oxalate. He's like, man, you're leaving me, ditching me out. He's like, man, I'm going to do something. What is he going to do? That oxalate is going to get reabsorbed by the gut, causes calcium oxalate in the kidney. So it gets into the blood, gets excreted in the kidneys. Kidney, man. Okay. And when it is in the kidney and calcium from the blood is coming into the kidneys, like, wow, I found my partner. So let's just join together. Okay, so they join there. But the problem is that joining is giving us a pain. That pain is stone. Okay. All right, let's talk about bilirubin now. Bilirubin. Heme is metabolized by heme oxygenase to bilirubin, which is green, which is subsequently reduced to bilirubin, which is yellow, brown. Unconjugated bilirubin is removed from the blood by liver, conjugated with a glucuronate and excreted in the bile. So you have a direct, indirect bilirubin. Direct means it's conjugated with glucuronic acid, and it is water soluble, dissolved in water. Indirect bilirubin, which is unconjugated and water insoluble. Direct, dissolves in water. Indirect, insoluble. So let's read. In the bloodstream of the RBCs. RBCs are getting destroyed by the macrophages of the reticular endothelial system, and it's converted to heme. Heme goes and gets into the unconjugated indirect bilirubin. That goes into the blood again and binds albumin. So you have the unconjugated bilirubin albumin complex. That unconjugated, remember right now we have an unconjugated bilirubin before you hit the liver. You have the unconjugated bilirubin, and the albumin has to bind to it. Why? Because it is insoluble. It's not soluble in water. So it's an insoluble thing, so you have to bind albumin. The albumin binds to it and forms a complex. That complex go to the liver. In the liver, you have the conjugation occurs and forms the direct bilirubin. So by the enzyme, which is called UDP glucuronyl transferase, and that forms the conjugated bilirubin. That conjugated bilirubin now has to go out from the liver, right? So it goes into the bile canaliculi and goes into the bile ducts and gets either stored in the gallbladder or just gets out into the duodenum, into the gut, right? So that when it gets into the gut, now what happens is you have this intestine. So now you have this cholesterol. Also, you remember the bile contained not only this not only bile, but also had the cholesterol. Cholesterol was part of that bile, right? So you have the cholesterol and the CB. What is that? CB, common bile, conjugated bile. Okay, so just let's go back because we don't want to make any confusions on this easy stuff. Here, you have this bile, conjugated bile comes out. Okay, that gut bacteria acts on it and forms urobilinogen. That urobilinogen is 80% it goes out, 20% it gets reabsorbed. 20%, let's talk about this 20% at the moment. 20%, which gets back into the blood, of that 20%, 10% goes in again into the urine, into the kidneys. It gets secreted by the kidneys, gets filtered in the kidneys, and goes into the urine and gives it a yellow color. That 10%. The remaining 90% through enterohepatic circulation, like that blood goes to the liver, right? So it goes back into the liver. That's only the 20% of that, all of that urobilinogen, right? So here the 80% that it's going to go out in the feces, called stercobilin, which gives the brown color to the stool. Okay, this was pretty easy. No. Okay. That's pretty much all what we have for physiology.